Right, so let's have a look at this one and see what people think. So I'm just gonna, so yeah, please feel free to throw in your answers. Tell me what you think is going on. And what do we think? What do we think? So this is an adult patient. I think they look like they're slightly rotated, don't they? So for those that don't know, what you do is you look at the medial ends of the clavicle and make sure they are completely aligned with one another in terms of with regards to the spinous process. And the spinous process should really be sitting right down the middle. But actually, we don't have that. We actually see that that spinous process is there, and we're slightly closer to this medial aspect of the clavicle. So they're kind of slightly rotated. So with this one, we do actually have a question to come up. So what do we think this is? What do we think is happening here? So I said, which one of these do not cause these appearances? So people are putting in their answers. I'll look at those answers in just a minute and while we work through. So I assume people have noticed that there is something clearly quite abnormal with regards to the mediastinum. Someone has said a bronchogenic nodule. I mean, that's not a terrible shout, but actually there are multiple other nodules or lesions scattered throughout the mediastinum. I'm going to point those out for you there. So there's one there. You feel like there could be some increased density somewhere along here as well. Not so, maybe some increased density along here, but yeah, this is the most obvious one that we can see. Definitely here, right? Calcified lesion in the mediastinum. So what caused that? So rheumatoid arthritis doesn't usually cause calcified lesions, right? It's actually would maybe cause cavitating lesions on some occasions, but not calcified. So the other ones can cause calcified lymph nodes, right? Sarcoid, silicosis, lymphoma, especially if it's treated lymphoma. So lymphoma doesn't initially cause calcified lymph nodes, but in these some situations it can, where you just got this calcified lymph nodes after treatment, right? So this looks like a single calcified lymph node. There's something else like Carson's disease, a bit of an odd disease. I can't remember what it's like. You can get a singular enlarged lymph node adjacent to the mediastinum or esophagus that can cause calcified lymph nodes. Interestingly, I remember reading that in the abdomen anyway, you can get calcified lymph nodes as a result of having non-pasteurized milk. I don't know how that would even happen in the first place or why people even know that, but it's the thing, you know, genuinely, when you look around, you'll see people or see articles written about that kind of thing. But anyway, when you're looking at this X-ray, you can't see anything else really going on. They're not exactly a young patient. You can see that there is some significant osteoarthritis involved in both glenohumeral joints. See that little band there? That's a thin band of atelectasis, maybe a few more thin bands of atelectasis. Everything looks okay. So I would say this patient is in a rotated, slightly kind of bent over position, kyphotic position, and you've got this almost uniformly calcified lymph node located within the right mediastinum. Differential diagnosis would be, et cetera, like I say. Now, the thing is, it's really important to quantify that the patient is rotated, because I've too often seen people start worrying about this area over here. And you have to understand that as people get older anyway, you do get some very normal apical scarring on both sides, especially when the patient is slightly rotated. You're going to have that sort of abnormal looking appearance to the APC, something gets sort of overshadowing from the neck, the soft tissues of the neck, the chin. I've seen that kind of cause some shadowing, people calling that kind of thing. So just be aware that always quantify the limitations of your study. If they're rotated, if they're kyphotic or anything like that, then just say that, because then you understand that, okay, there's going to be some limitations to your interpretation, right? And just for those that want a little bit of a bonus point, you can actually see there's a little bit of atherosclerosis sitting within that aortic knuckle as well, but no widening of the mediastinum per se. And I know someone said widening of the mediastinum, but you also have to remember, right, this patient's rotated, so you kind of seeing them at an angle anyway. Look where that airway is compared to the rest of the aorta over there. You're kind of seeing it at this kind of rotated position, which means that the mediastinum is naturally going to look a lot wider than it otherwise would. Right, so let's have a look at this case. So this one, I think, okay, so I've seen these answers. Yeah, well done. So a few people went for rheumatoid. I wouldn't really go for rheumatoid when it comes to calcified lymph nodes. I would go for the other ones when it comes to calcified lymph nodes, unless you were saying that because of what the shoulders look like. But with the shoulders, they didn't look like erosive changes. They look like loss of joint space. And for those that don't know this, there was an acronym, wasn't it? Let me just, the acronym was it L? OSS, right? So it was loss of joint space, osteophytosis, subarticular sclerosis, and subarticular cystic change, something like that. So that would be osteoarthritis. And that's actually what we saw with the patient's shoulders rather than there being anything else. So I don't think we could go for rheumatoid arthritis per se on that. Okay, so let's have a look at this one. Yeah, interstitial lung disease. Can you mention which case you're opening so we can follow ourselves? Yeah, I wish I could, but I think for me, I'll try right now because there was a few issues going on with the platform itself, which is why I'm actually presenting it off my computer. I don't know if anyone from Collector Minds can give me an update. Let's see.